In 2018, over 1,000 pancreatic transplants were performed in the United States, the majority in combination with kidney transplant. These patients have a survival rate at 5 years close to 90%. The main indication is type 1 diabetes, either with or without renal failure, followed by pancreatic graft loss. Two surgical techniques are used, either enteric drainage, in which the duodenal segment is anastomosed to the recipient's small intestine, or bladder drainage, in which the duodenal segment is anastomosed to the recipient bladder. For patients with enterically drained pancreatic transplants, the most common late vascular complications are formation of arterioenteric and arteriovenous fistula and pseudoaneurysms, with anastomotic side bleeding usually an early complication. To varying degrees, these can all result in gastrointestinal bleeding. With increasing numbers of enterically drained grafts and/or enteric conversions after initial bladder drainage, obscure GI bleeding can be the initial presentation of a vascular complication. For some patients, a sentinel bleed might be the initial presentation, while others can present with acute hypovolemic shock and severe hemorrhage, as compared to other causes of more indolent obscure GI bleeding. We aim to report the incidence of gastrointestinal bleeding as a complication from pancreatic transplantation. We performed a systematic search of the published data regarding gastrointestinal bleeding due to complications from enterically drained pancreatic transplants, finding 34 publications for a total of 67 patients. Sentinel GI bleeding was reported in 55% of cases, and the timing of GI bleed ranged from 1 week after the surgery up to 10 years after transplant. The most common etiology was arterioenteric fistula, followed by anastomotic ulcers. Diagnosis was made by angiography in 28% of cases, followed by surgery, and only in 7 cases was endoscopic diagnosis successful. Surgery and procedures by IR were the mainstays of treatment. Overall, 49% of patients had pancreatic graft loss prior to their episode of GI bleed. This is important as it is thought that as the allograft fibroses and decreases in size, the bowel anastomosis is pulled toward the area of vascular anastomosis, increasing risk of developing a communication between the artery and the native intestine. In this series, up to half of the patients had already developed pancreatic graft loss. Clinicians should have a high index of suspicion for vascular fistulas in patients with pancreatic transplant in order to be able to establish a diagnosis. It is important to note that there is a limited role for endoscopic procedures, both for diagnosis and management of GI bleed secondary to these complications. Delayed diagnosis and treatment of life-threatening hemorrhage can occur if clinicians are not aware of these associations.